Hi, my name is Frank Caputo, and welcome to Drugs Are Us. This program is dedicated to hopefully educating the families of people that may have family members that have substance abuse problems or potentially have them. My guest tonight is Dr. Karen Guadagnini. Dr. Guadagnini is a practicing physician in Bristol. She's also the Associate Medical Director of the Counseling Center of Bristol Hospital. And we've gone back a long time and, in a variety of capacities. And I've asked Dr. Guadagnini to come here tonight to discuss some of the medical aspects of substance abuse and addiction. Maybe the first question I should ask you, Doctor, is between the difference between substance abuse and addiction. What would be addiction to a disease or dependence on a disease?
Thanks for having me.
You're welcome.
I think the difference is addiction and addictive behaviors result because initially use of any substance or any behavior makes people feel good. And then after a while, continued use no longer serves a purpose of making them feel good or be less depressed or less shy, and the addiction becomes the problem. And they no longer then see that problems that occur in their life can happen because their use of alcohol or drugs have such an impact that they are no longer living a life, but living a life to seek drugs and continued use.
So they are actually dependent upon the chemical.
Yes.
At that point,
right.
Physically and psychologically.
And psychologically,
Okay.
both, yes.
If a person says that they can handle it, perhaps for, well, I only drink on weekends or whatever the case may be, can a person with that particular pattern also be considered an addict or an alcoholic?
It's an excellent question because most people consider themselves that kind of user or drinker.
Okay.
And it depends on what effect it has on you. It's not so much how much or when, but how much effect or negative impact does it have on you, your life, your health, your work.
So it's what it does as
It's
opposed
what
to
it
just
does.
the chemical itself.
Exactly.
I was going to ask you that too, but it's been around for a long time though, hasn't it?
Yes.
Use of mind-altering substances.
Yes.
Can you give us some idea? I know you have some graphics here which you'll put up on the board as to how far this does go back? Or?
Some great pictures. There's a picture we have here of inebriated revelers, they're called, being carried away from a party. And this was actually a painting from an Egyptian tomb around 2100 BC. And they're being carried away from a banquet after too much wine. And although they were drinking to excess, and it was not that uncommon, it was probably safer then to drink alcohol than it was to drink the water over 4,000 years ago.
Why is that? Why is that?
Well, because of the lead levels in the water.
Lead levels?
Yes.
Oh, that's interesting. Yeah.
We no longer have that reason not to drink water and drink alcohol
I hope
instead.
not. I hope not, no.
But it was a good excuse then.
Yeah, sure. Why not?
And another painting found on one of the Egyptian tombs around 1400 BC shows basically two slaves who are doing early distilling and purifying of whatever substance, I'm assuming it's wine in this one, because their job was to make it as delicious and clean as possible for the king. So basically they were actually being, they were ingesting toxins in order for the king to have the better stuff. Yeah.
Isn't that lovely?
And around 1400 BC, so
we don't have
way
those
long
around
time.
anymore either.
No,
I
and this is a picture from a page in a book by a German author, and it's one of the first books on distilling. And distilling helps create drinks. They were spirits, such as vodka, gin, rum, bourbon, and this in around 1500 AD. These folks had a very elaborate apparatus, as you can see here, for distilling.
Yeah, that's great.
And they showed that the more potent the drink was, which is what their goal is, the distilled alcohol would do the following things. It could cause a good color in a person. It would heal baldness.
Oh, really?
Kill lice and fleas. Give courage in a person, and cause him to have a good memory.
Yeah.
So, all those promises.
Well, the only way I can look at it in this thing is the give courage part, because I know a lot of alcoholics that have a lot of courage and don't understand why they do at the moment, and they feel sorry for it the next day.
Yeah,
But, that's really interesting. So,
Yeah.
so these things were accepted over a long period of time.
As long as we can remember, and as long as people are able to draw pictures, it looks like. It's not unusual for us to seek ways to change the way we're feeling. You've even seen children. Have you ever seen a little kid spin around till they get dizzy and fall down?
Yeah.
Same idea.
Same idea.
They keep doing it and it's fine, but after a while they stop doing it because they keep falling down and you get up. Right.
It's interesting because it's not something that's brand new. People look at it, especially I'm familiar with cocaine and heroin, so on and so forth, opiate therapy, and they've been going back for many, many years, but it gets a lot of press nowadays. I guess we didn't have that much coverage. When I was a kid, the only people that smoked marijuana and snorted cocaine were musicians, or bohemians, or whatever the case may be, and hippies did LSD and so on and so forth.
The creative people.
The creative people,
right,
that's right. Sigmund Freud, unfortunately.
Right.
But it's a wide variety of the options. Let me ask you something about the effects of alcohol and drugs on different people. There's a book that I have which is called I Wish You Could Drink Like a Lady. And it gives the connotation that, well, if she drank like a lady she'd be all right, but she drinks like a man. Is there a difference between what a man and a woman, how they react and how it's handled by the body?
Yeah, absolutely. In fact, drinking like a lady is much safer for the lady because there is a difference between men and women, probably hormonal, and again, it has to do with enzymes that break down alcohol in the stomach and probably other things in the liver. But women experience what is called the telescoping effect. And we all know that a telescope brings things in closer when you view them. So the telescoping effect has been well documented that women who drink the same as men, the same amount or the same amount of time as men, get sicker sooner. So they experience that telescoping effect. So let's say a man and a woman come to me for treatment and they're about the same age, been drinking the same amount over the same number of years, she will be sicker than the man with end organ damage, heart, liver, brain. That kind of thing, nervous system. Yeah.
That's interesting, because I guess the rule of thumb, people say, if you're a big person, you can drink more than a small person, but it doesn't necessarily.
Not necessarily, and there are women who can tolerate a lot of alcohol and, quote, drink like any man. The problem is, I think it's evolutionary. We weren't meant to drink like men, probably for reasons of protecting protection during pregnancy and having babies and ongoing, that kind of thing. So we were never intended to do that.
That's true. You're bearing the young, you can't drink.
Exactly.
Of course, now that's really kind of like the rule now, isn't it? As far as if you are pregnant and drinking.
Right.
How you manage.
Well, I advise people drinking once in a while when you're pregnant is probably fine, but not drinking at all is definitely safe. And also I have to remind folks who are breastfeeding as well, anything in the bloodstream is in the breast milk. So if you're intoxicated, so is the nursing baby.
That's very true.
Yeah.
That's very true.
Right.
There is something which we've seen on television many times, including on Law and Order, I guess, it's called fetal alcohol syndrome. That's something that is. I'm not sure it's real, but is it something that really is a problem?
It's real, and I think it's for people who drink alcoholically during pregnancy. That occasional glass of wine is not the issue. It's someone who drinks alcoholically and causes damage to the fetus in many ways, mental retardation, developmental abnormalities, and it's one of the top causes of mental retardation that's entirely preventable by just not drinking when you're pregnant.
Yeah. It's true too. True too. That's interesting. May I just say something also at this point? We're talking about alcohol, but I'm sure that the use of other drugs during the pregnancy is just as dangerous. Well, just as dangerous. Period.
Absolutely. And actually, opiates per se tend not to be too dangerous for the mother or the fetus unless used in an addictive way. And then you have an intoxicated or high mother and a high fetus. And same with breastfeeding. And actually, just a note about other drugs. Alcohol is probably the #1 drug problem after nicotine and tobacco use in this country. And what's gaining favor, especially outside of the ghetto where we think heroin and cocaine happen, is in the suburbs, Farmington Valley, Hartford County, New Haven. Now people can afford and have access to cocaine, high-grade heroin, and other party drugs which are dangerous because especially the heroin, it is such good quality that people, there are actually deaths reported just from snorting, not even, intravenous use. Yeah.
It's interesting to say that, because people have this impression and stereotype of people that are addicts and so on and so forth. And I have to tell you from the other side that I've had nurses, I've had lawyers, I've had public officials, I've had policemen, police women, I've had physicians. Yes. Who have a problem with that, right. And it's not restricted just to the individual person. That may be, like I said in a couple of other programs, living under a bridge cooking squirrel or something. You don't necessarily have to be that way. You can be driving a Mercedes and still do the same thing.
Exactly. There's no typical alcoholic, as we say. Alcoholics look like everyone else, and therefore it sometimes makes the diagnosis or the ability to intervene more difficult, because alcoholics do look like us. And a lot of alcoholism is continued through many problems before it becomes such a problem that the person's disabled. That's why we want to intervene early, before they have medical consequences. By the time they come to me with medical issues, or I think they're going to have there's some problem either in their work, their family, or something else that alcohol has impacted. Because the problem is they cannot stop drinking, or they cannot stop drinking consistently. So a very typical alcoholic will say, well, I went to the party and I didn't even have a drink that night. But they never know what party that may or may not happen at, and then they drink out of control the next one. And so it's an unpredictable, inconsistent loss of control. And if we're all about, well, I'm just going to quit, then we wouldn't have any alcoholics. If it were about willpower...
Then I wouldn't have a job.
Yeah, our lives would be different. But if it were about willpower, would there be any alcoholics? No, no one wants to be an alcoholic.
No, of course not. I get a kick out of people that say, why did they do this? And I may have mentioned this before too, but one of the bumper stickers that I hate are the ones that say drugs don't work, because drugs do work. And when they try them, they find out, and then it makes life easier for them, and then it makes life more difficult for them.
Right.
Are people, when, let's say I come to you and I say, gee, doc, I've been having these, whatever my physical symptoms are, and you have a feeling that maybe these things may be related to alcohol. If you ask me, Frank, do you drink a lot? What percentage of people actually tell you, yes, I do?
That's a great question, because you almost, I'm going to say never get the real answer, at least not initially. Because the one thing that an alcoholic or even a drug using person won't want to tell you is what they really drink or what they really do. And it's less important initially as it is the question, it's not how much you drink, but how much of an impact is it having on you? How much trouble is it causing you? So sometimes, as a physician, we want to make diagnoses all the time. But sometimes, rather than get into that a little bit of a conflict with the patient, the important thing is, what about it is the problem? Do you see a connection between your drinking and home life, or why are you failing out of school, or why are you losing your job, and that kind of thing? And then get on to the diagnosis. Because to tell someone, well, you're an alcoholic, I rarely get, oh, well, that's good, thanks, I'm glad to, because we need to have something to go on. And so a lot of times they'll say, I think alcohol may be a problem for you. People with hypertension or diabetes or asthma or that kind of thing, we can talk to them, or cholesterol, we show them numbers. Sure. But with alcoholic and drug addict folks, we need to be able to talk to them in ways that it shows where it's having an impact negatively on their lives. Yeah.
And they have to be honest with you, because you say there's no diagnostic test, there's no blood test, there's no diagnostic imaging that's going to say you have a problem with alcohol, because at that point it may not have gone that far.
Exactly, and there are some, but by the time you're looking at pictures of the damage, we wanted to intervene sooner, because there are ways that we can look at this, and there's still ongoing research, blood tests, imaging, PET and SPECT imaging and all that. But again, you're looking at changes that may be years down the line from when they first would have benefited from intervention. Same as having a stroke after untreated hypertension. That's when you find out, well, I had high blood pressure.
That's interesting. I know that you have a background in addictions in addition to your general practice. And I'm not sure that a lot of physicians do have that, but you have had some time in the past. You actually did your internship, I believe, in the Bronx or something,
Right.
and you studied a lot of people that had addictions.
Yeah, well, I did my residency in the Bronx. A lot of addicts and alcoholics. It was mainly City Hospital and other things. So that we had lots of folks like that. And HIV was just becoming a real issue. Hepatitis B and C. Then I did a fellowship in alcohol clinical research at the VA and studied. Some wonderful studies were done there because it was an NIH center on folks who were drinking and using maybe certain medications and how it affected the absorption of alcohol and what would happen if they took that pill and the drink. So lots of good research on enzymes and hormones and levels of alcohol.
So you are more likely perhaps than maybe some other physician to, if you see a person in the early stages of an addictive process, to make a referral to a treatment program
Absolutely.
of some sort, whatever the case may be. Do you think that perhaps there should be a little more education out there for physicians regarding what's available for treatment?
Absolutely. I think since it's such a big part of any primary care or other type of practice, if we know that 1 in 10 people are probably alcoholic, and we certainly ask questions about blood pressure and blood sugar and family history and all that, why wouldn't we ask a question about alcohol or drugs? It will only help them. And if we couch it in terms of, this is your medical history, this is an important part of what we need to know about you, so that we can do the best we can to help you out. And I think a lot of physicians are slowly getting a little more comfortable with asking those questions. And I think the reason is now we do have things available to help folks, the counseling center and other programs, support groups like AA and NA, because I think when we ask the question and we may find there's a problem, how can we help them? And if we don't feel we have some place to refer them, so absolutely. And there's information, all kinds of ways you could find that out now, which is great with the internet and community resources and this kind of programming too.
Yeah, because I know Just Say No doesn't work. And,
no, if that worked, well, that'd be great.
Yeah. And I've also found on my side of this, and I'm sure you have on the medical side of it too, that fear is not always the greatest motivator in a situation. If you tell someone that they are physically ill and if they stop drinking, things will get better, they still don't stop many times.
No, or your blood sugar is so high, if you don't take your medication, you're going to get kidney damage. No, something must happen to show that if they don't change, it's going to get beyond our control completely. And we it's a different level for people. I think when the doctor tells you that you're going to have some physical problems if you don't stop, or you already do, I think that does help motivate some folks. Yeah.
So what you're saying is a lot of physical problems, a lot of reasons that people are being treated for physical illnesses or hospitalized, whatever, for physical illnesses, is connected to some type of substance abuse. A great percentage of that. How would you?
Yeah, it's a surprising thing. Maybe 1 in 3 in a hospital, any kind of hospital, where it's a community hospital or an inner city hospital, 1 in 3 to 1 in 4 folks in that hospital have an alcohol or drug problem, and they may be there for another reason, but it's in those terms. They may come in for a gastrointestinal problem, may come in for an infectious problem or surgery, but 1 in 4 of those people has a drug or alcohol problem that may have prompted that admission to begin with, or develop as a problem while they're there.
And that is the person themselves, not a family member who, for example, might come in because of injuries because a person was intoxicated and abused them, whatever the case. So,
right.
If you start relating those, you get quite a bit.
You do. Domestic violence, traumas, accidents, depression, suicides, almost all have some connection to alcohol.
You always scare me when you give the statistics that I've heard in the past on who's the most likely to commit suicide.
Well, it's usually it's a man who's alone, middle-aged or a little older, who's drinking and is depressed, and in a moment of disinhibition will take his life in a way that's often more violent and more complete, so to say. You know, yeah. That's the typical picture. And those folks, when they threaten suicide, you take them seriously. Because when someone's intoxicated or high, they may just do it. So again, is it depression that came first, or alcoholism, or did one cause the other? We used to say in the old days that we would just help them get sober and then see if they needed antidepressants, but now we know there's such an interconnection that we treat both. Because if someone's newly sober or newly in recovery and they need to work a program and they're too depressed to do it, they may relapse. So we help them. We help them prevent relapse, get on with the work of staying well.
Yeah. In the field of counseling and therapy, there's always been a term called dual diagnosis, which means that a person who is diagnosed with an addiction to a chemical may also have another behavioral health disease, which would be depression, anxiety, OCD, whatever the case may be. But we don't look at it, now it's called a co-occurring disorder. But it's strange that there are a lot of co-occurring disorders that are physical in addition to the alcohol or the drug problem.
Absolutely.
And what you're saying is basically what the people in the mental health field are saying now about co-occurring disorders is that you have to treat both at one time. You don't clear up the physical problem and then address the drinking problem or the drugging problem. You have to do both at one time.
That's right.
And that's interesting to know that.
Yeah.
It's kind of like, well, when I get done with this, I'll do this.
Right.
It doesn't quite work that way because one is kind of dependent on the other.
It's the medical treatment approach. It's the same as if someone has, again, blood pressure, high blood sugar, and high cholesterol. You don't always wait to get one in control before you get on to the next because they co-occur.
That's right.
And they do much better with treatment of the full spectrum of what's going on.
Right. Very interesting, very interesting. Well, what we're talking about tonight is, for those, I may have mentioned this in another session, if I didn't, I probably will, that has to do with the fact that this is a biopsychosocial disease.
Right.
And tonight we're kind of putting the attention on the biological part, but there's a connection. I mean, it doesn't just stop with the bio part and then begin with the psycho part and then end with the psycho part and begin with the social part.
That's
There's an
absolutely
interaction amongst them. Even the social part of it. If you're hanging out with a bunch of people that are using drugs and alcohol, there's a better chance you're going to wind up doing it yourself. Okay. Right. There's also a better chance of them telling you, no problem. Your liver will go right back to where it's supposed to be. You're in good shape. It'll work out very well. Yes.
Right.
Take a little product.
And I think as physicians, especially primary care, which I do, we are seeing a lot of these folks on a regular basis, and diagnosed or not. And I think our job is to help them. And if it's to at least even give them the idea that they may have a problem so that we can steer them in the right direction and look at the blood pressure that's not controlled because they're still drinking, or their blood sugar that's not stable, or their liver disease or something. But again, even before it gets to that point, it helps to say something, because I think it's important that somebody say something. A lot of this for folks who are working to stay sober or to get well, some of it's painful to deal with, some of the stuff that you may have been doing or done, but it's not harmful. It always will work out well in the end. Treatment is not always easy, but it's worthwhile.
No, it's not.
It gets people well.
Right. It's not. The situation is people want. I know they want instant gratification, which is why they were using the drug.
That's exactly.
Hey, I feel great.
Right.
And I know that I'm sure that you, as a physician, have seen people that are trying to mask their symptoms with whatever chemical they're using.
Right.
Do you feel good? Oh no, I feel fine. A friend of mine gives me Percocets, and I take them 7 times a day, so I have no pain. Okay, so that doesn't mean the problem is that.
That happens for
I'm sure it does. And I've got to ask you the obvious question too. Physicians are prescribing painkillers, okay, and they should be prescribed for pain.
Absolutely.
And if they are taken for pain, they should be right. It should work, okay. Is there a difference between a person that's prescribing just for pain and a person, a physician that perhaps, well, I guess what I'm asking is, are there different qualifications for a pain management physician who is prescribing for pain control, as opposed to, I've had a tooth extraction, my dentist gives me a prescription for 10 Percocets and I take them and it's done. But for long-term care, are physicians actually certified to do long-term care? Is it a different type of a training to do that?
Absolutely, and I think as there should be, because we do need the expertise of pain management folks for some of these people who have real pain and are needing high-dose narcotics and need some help. Short-term, a few Percocet after tooth extraction, that's not an issue. But I think it's important to keep in mind that it's sometimes difficult to tell a difference between when someone's seeking medication for fun or for pain. And sometimes we aren't always sure. Yeah. So I always err on the side of try to help the patient, but then steer them where I think they may need to go.
Yeah. And I hate it bothers me sometimes when people say, "Well, I blame the doctors; they give them the medication." It's very difficult if the person's not telling you the truth.
Exactly.
Because you have to believe what they
That's
say.
Right.
Because I deal more with the emotional pain on my side of the issue, but you deal with physical pain, and I'm sure that it's hard to judge that unless you actually ask the person, what's your pain level from 1 to 10, and if they say it's 9, you have to kind of believe that it's 9, even if it's a 3 and they really want a little extra medication. It's hard to do that.
And their emotional pain can be a 12, and since it's so interconnected,
yes.
And that's where antidepressants, program, that kind of thing can help folks too.
Right. Yeah. But don't take antidepressants if you're continuing to drink, right? It doesn't work that way.
Well,
right?
They won't work as well.
No, I don't think so.
No. Bad things may happen.
Yeah, well, I've heard people that will do that. Well, I shouldn't be depressed. I'm taking this medication. You're still drinking.
Right.
Well, I really thank you very much for coming here tonight.
My pleasure.
Again, it's a biopsychosocial disease. It's more than just willpower. It's more than just physical addiction. It's a variety of things. But people have to face the fact that it does affect the body, and the body does become dependent on it, and it can ruin the things that are part of your life. So I thank you so much. It really was nice to see you again.
Thanks for having me.
If I have any questions, I'll call you.
Okay.
Thank you very much.
My pleasure.
Good evening, everyone. I hope you enjoyed tonight's program, and tune in again next week, and we'll see you again. Take care. Have a good night.
Ooh.